Welcome back to the Last Visit First podcast. Today, I'm very honored to welcome Dr. Jason Kimbrel. He's a name synonymous with Hospice Pharmacy Solutions. Jason is the Chief Operating Officer at Yellow Leaf Consulting. He's worked as a hospice leader in many great companies like Hospice and Optum Pharmacy Solutions on the hospice side. He's been guiding strategy and innovation in clinical practice at a national scale for many, many, many years. With his Doctor of Pharmacy training, Jason has elevated standards for medication management in hospice while becoming one of the most trusted and respected pharmacists in the field. I've known you now, Jason, 15, 20 years.
Yeah.
His insights bridge bedside compassion with system-wide pharmacy strategy, shaping how medications are understood, delivered, and used at the end of life. Today, I really want to jump into Jason's journey into hospice, the evolving role of pharmacy at the end of life, and the balance between cost and comfort. Jason, welcome to the Last Visit First.
Thanks, Tom.
This is awesome. I'm so excited to finally sit down with you. We worked together for many years when I was at Home Care Home Base, and then we were competitors when I was over at Clara, and now you're out in the industry again. And it just goes to show you should never be mean to your competitors.
That's right.
Or they're not gonna join you on a podcast.
That's right. That's right.
Jason, you spent many years leading hospice pharmacy. Talk to me. How did you get here? How did you get to hospice?
Yeah. So great question. I'm gonna take a step back and kind of share a little bit of that journey. So I graduated from Ohio Northern University, and when you're completing your pharmacy doctorate program, one of the things that you have to do is you have to go do these clinical rotations, and usually go out every month and do a different one for like 9 months. And one of the a lot of times pharmacists have a tendency to do things like stay around the school or maybe go back to their hometown. And so I did some of that, but I had this sort of inkling desire to go somewhere else. And so I found myself scrolling through all this paperwork, and I ended up landing in Maine. So I actually moved to Maine for 3 months, and I worked with the good folks at Eastern Maine Medical Center. So I I had really good feedback on all these rotations, and things were going really well. And I ended up there in Maine, and I was there for about a month or so. And the pharmacist preceptor came in that morning and said, "Hey, I need you to work on something for the hospital. I don't want you to go to rounds, so I'll catch up with you later." No big deal, right? And so I was like, okay. So I went to the office, worked on stuff, and he comes in later in the afternoon and he says, "I got to talk to you about something that happened today." And I was like, okay. And he said, I've had a lot of pharmacy students, I've had a lot of residents, I've had a lot of pharmacists that have trained with me. He was like, "But the floor called down and was like really mad that you weren't at rounds today." And he was like, I've never had the floor, or the hospital call down and like demand that you get up there for rounds because they were waiting for you to start." So, I mean, like, granted, this was 20 plus years ago, right? And so rounds started if you had the physician there and the nurse there. Like, pharmacist was like extra support. But so he was like, "I don't know what you're doing." He was like, "But you're doing something that really resonates like with them." And so I kind of like was like, "Well, what am I doing?" Right? I mean, what am I doing? And I think what I was doing, and I kind of realized it was sort of maybe I'll call it my superpower right at that point, right? Was the ability to live in the gray. And so pharmacists have a tendency to be very black and white, right? I mean, I'm going to give you tell me what the diagnosis is, I'm going to tell you what the first line drug therapy is. You give me the lab value, I'm going to tell you exactly how to change the dose, right? And it's very yes, no, algorithmic. And I was always good at that, right? But I was really supportive of being able to live in that gray. And because of that, I think I made a lot of inroads, right? And so I found myself in residency. So I came back home. From Columbus, Ohio. I came back home. I did my residency at Ohio Health, which is the health system here in Central Ohio. I did my primary care, general medicine there, and did patient safety there as well. And I ended up meeting up with Phyllis Grauer, and Phyllis Grauer was a very influential pharmacist in the hospice space. So she had been doing hospice for a long time here in Central Ohio and started her own consulting company It was kind of like really at the beginning forefront of bringing pharmacists into hospice. So one of the things that Phyllis was really involved with was the Transatlantic Project. And if you look back at the Transatlantic Project, right, that was where you had information coming from the UK back over to the United States, and that project had gone on for a long time. And so you saw that influence, right? Even with the first hospice in the country, Connecticut Hospice, you saw that with the CMS creation of the hospice industry from a Medicare benefit perspective. One of the things that Phyllis was involved with in that transatlantic project was medications. And the interesting thing about that is there was a company here in Central Ohio by the name of Roxane Labs. And Roxane Labs worked with that transatlantic project in Phyllis, and they were looking at how to make medications available for patients who are having a hard time swallowing. And so what you got out of that, right, was Roxane Labs made Roxanol. And Roxanol is concentrated morphine, which is the number one drug used all across hospice even today. And
Wow.
so Roxane Labs made Roxanol, and then they made things like lorazepam intensol, haloperidol concentrate, Valium concentrate, and and a bunch more. And that sort of kicked off this hospice pharmacy sort of ability. And so Phyllis actually pulled me in, and while I was at Ohio Health, and said, "Hey, I think you would like hospice. You should come over here." And I was like, "I don't know anything about hospice, but sure, I'll be happy to learn about it." And so I ended up popping over there and learning a little bit about what hospice was. And that was the pivotal moment, right? Because it was where I realized what I thought was that superpower where I felt like I could operate in the gray. I realized that hospice was all in the gray. It was exactly where that emotional sort of connection was. You don't have, you got to remember hospice 20 years ago. I mean, if you went to certain parts of the country 20 years ago in hospice, it was gunslinging. It was, oh, patient has pain. I'm going to tell you how to, I'm just going to double the dose of morphine until they're comfortable or they die. It was, you could go to various parts of the country, and it was very gunslinging, not a lot of documentation. And that operating in that gray sort of gave me that ability to really sort of connect, right? Because I was able to sort of use that to sort of say, let's talk about what we can do and what we can't do. And let's talk about how to move the industry forward without having to sort of say, no, right? You're wrong. We have to do it this way. And that to me sort of resonated really for me personally, and sort of just made me fall in love with hospice.
So who were you working for then? You were working for Ohio Health, and you were kind of just in your rotations, and then
exactly. So I was finishing my last rotation at Ohio Health. So I was postgraduate, right? I already graduated. I was licensed pharmacist in my postgraduate residency. And so she kind of grabbed me at the end. I was almost actually going to take a job as a patient safety officer for the health system. And she said, "You should come over here and look at this hospice sort of thing." And then I was like, "I'm not leaving this," because I absolutely just fell in love with it at that point. And so it was interesting. And so she actually offered me the job, and then so come over to her consulting company.
that's wild. Okay, now follow your career. So after
Yeah.
that, where did you go?
So that ended up being Palliative Care Consulting Group, and so that was PCCG. And so we had PCCG as a company, and we sold that company to a company called Hospice. And so Hospice Script was founded in 95, and I think Hospice Pharmacy was founded in 96. So to kind of give you a timeline of where they were at, they were kind of the PBM sort of, oh my gosh, let's do something in the PBM world, right? And so Hospice Script bought Palliative Care Consulting Group to sort of create some clinical excellence. We sold Palliative Care Consulting Group to a company. We sold Palliative Care Consulting Group to Hospice Script. We sold Hospice Script to another company called Catalyst RX. We sold Catalyst RX to a company called SXC, or Systems Excellence, which was actually a Toronto-based company, who then moved themselves to Chicago, Illinois, and rebranded themselves as Catamaran RX. And then Catamaran RX had sold their company to United Health Group, to the Optum division. And so that is where Optum Hospice Pharmacy Services came from in that legacy sort of journey. Now, as it states today, Optum Hospice Pharmacy Services was divested. Optum divested that business away, and I was able to join up with some colleagues here um, to do some stuff with Yellow Leaf, and we're doing some stuff obviously in healthcare, not in healthcare, in hospice, not in hospice, but all kinds of interesting stuff there.
Cool. Where did Yellow Leaf name come from?
Yeah, honestly, it was one of those things when you got a bunch of colleagues and they're kind of like, we got to come up with a name of something, right? And we were throwing things around or something, and I was like, well, maybe we got to come up with a color. I don't know, maybe we got to come up with something, and for whatever reason, we were just kind of brainstorming, and it was kind of one of those things where we sort of said, you know what, we work with all of these great organizations, we work with all these great people, like, what do you what do you think about this idea that, like, when you see a plant, right, and you see like it has one yellow leaf on it, right, you kind of think to yourself, well, maybe they need some help, or it needs some support, it needs some water, it needs some fertilizer. I mean, it doesn't need I need to rip the plant out and destroy it and rebuild it again. And maybe it just needs a little bit of support in some of these areas. And so we thought to ourselves, well, isn't that what we want to do? Don't we want to kind of come in and sort of provide a little fractional support here, or maybe a little bit of help here? And so isn't it kind of like, we're helping them with their yellow leaves? And we were like, sounds like a good idea. Let's go with it.
That's a cool name. I didn't know the story. It's kind of like when
Yeah,
I
it was
was,
one of those where it came out of a very long text chain. Let's call it that.
yeah, it's fun. We, when I founded Muse with Brian Moser and Jennifer Maxwell, we're trying to come up with a name. It was going to be Hospice something, something predictive analytics. And I was sitting in front of my computer and, just kind of staring off into the mountains and, here in Scottsdale, and my screensaver on my computer has the word of the day, and Muse came up as a word of the day, and I saw it and I'm like, huh.
Wow.
And it said, Muse, it's the collaboration of multiple people to solve one problem. And I'm like, that's what we're
Awesome.
doing. And I
Well, that's
texted Brian and Jennifer, and I'm like, Muse, it's got to be the name of our product. And he's like,
yeah.
I love it. Of course,
Yes.
Muse also means a goddess princess. And so Jennifer Maxwell always says, that we named it after her, but it's a joke. But no, it was
That's
wild. I
hilarious.
didn't know about Yellow Leaf. So you guys are focused on some hospice services, but you're doing some other stuff in around healthcare, and that's cool. Yeah, good for you and Brent. That's awesome. What makes a hospice pharmacy unique, different from other pharmacy disciplines? And I know you guys do a lot of different stuff, but what makes you really unique?
So if you just look at pharmacy in general, right, for hospice, I think really kind of appreciating that idea that it really is somewhat in the gray, right? And so I think if you look back in hospice along the timeline, you sort of see this idea that there's a lot of things that people do that just were never documented, were never really, researched. We're kind of, oh, let's just try this and see what happens type of thing. And so, um, that's one of the things I think that for me was as I got into it, really was kind of a foundational piece, was like, how do I, sit down and how do I work with, these other folks, and how do we create some of those foundational pieces? And so, I think if you look at, like, just for an example, like if you look at like atropine, right? Everybody uses atropine drops for terminal secretions or whatever, but like there really wasn't any documentation on it. Like, and so like we sort of sat down and we said, okay, well then let's go do a study on it, right? Let's go into the inpatient unit, right? We're going to give atropine eye drops to the patients, less like they always would have done, right? But we're going to monitor the efficacy, we're going to monitor the side effects, and we're going to actually, publish something on that. So we did a lot of that type of work. So if you look back, I think at this point, I think I had a three book. I think we published three books. Helped publish three books. I think we have like 20 plus journal articles that I've helped write over the years. And so that was kind of like one of the things that like I and some of the colleagues I worked with were really kind of um, was a big deal for us. We sort of said, like, how do we make pharmacy hospice, like, it's so different, like, because you have to be in the gray, you have to be uncomfortable with stuff, you're not going to get labs. Like, I mean, that was one of the things when I train new pharmacists, they're, and they're always like, well, what's the labs? I'm like, you're not going to get labs in hospice patient. Like, you have to be able to tweak the drugs, and you got to be able to decide what to do without all of that stuff, right? And so if you think about it, there's like so much good documentation that says, "Oh, you have heart failure. Well, Tom, I want you to take this med, and this is the second thing I need you to do, and this is the third thing you need to do, and these are all the things we need to do for your life." But you're going to be hard pressed to find this algorithm flowchart that takes you away from it, that says, "Oh, well, Tom's heart failure doesn't, we can't do anything more. So how do we take this away? How do we peel these drugs back?" Right? And so that's not really documented anywhere. And so you have to understand, like, even though like maybe an ACE inhibitor might be your first line therapy in heart failure, it might be one of the first things we take away in hospice, because I'm not necessarily looking for long term, I'm not looking for years of symptom control. I'm looking how to manage, in the next, you know, uh, 13 days.
I think it's interesting that hospice, I mean, as a pharmacist in hospice, you spend as much time looking at the medications they're on and really asking yourself, do they need this medication? Do we need to de-prescribe this? Do we need to, and not from a cost control perspective, but from a patient symptomology perspective, and do they really need this? Do they need to take all these things? And I know you have a great story you and I have talked about that we'll get to here in a little bit around that, and around getting yelled at by a patient's family members, but that's a good one. What's the biggest misconception that you see on hospice teams or even in families around medications or the end of life? Like, what's the biggest misconception?
Um, I would say that, well, in general, I mean, even today, if you find your way into any social media platform and look at hospice, you always see the conversations about, "Oh, hospice is going to stop all my meds. Hospice is just going to give me morphine and kill my loved one," right? And so I think a lot of opioid concern. I think a lot of um, the desire that I'm going to come in and stop everything, and it's really kind of cyclical, right? Because on one hand, it's like I do want to come in and stop the things, because I want to give you that freedom of, why are you on 17 different medications, like, when we don't really need that anymore? So on one hand, I do want to come in and stop things, right? And then on one hand, I do want to give you things like morphine, because I can use it for pain, I can use it for shortness of breath, I can use it for all these things. And oh, by the way, it's liquid and it's a volume, and I can, give it sublingually, I can do everything. I have all this versatility with it, right? But because of the negative connotations that you get with a lot of these drugs, you get an immediate response of, your goal here is just to put my mom on morphine, and your goal is just to sort of take all her meds away and sort of, you know, transition her, her life to the end, right? And I think it's so far from that. I think honestly, we've done such a good job over the last 20 years of changing that narrative. Because, like, as I said earlier, I mean, it was not, no joking aside, it was not uncommon that you got to parts of this country, especially in non-suburban or urban areas, and it was very much they would call you and they would tell you that their standing order for morphine was 5 to 100 milligrams every hour. And they would say, "I'm just, every hour I go 5, and then I go 10, and then I go 20, and then I go 30, and then I go 40, all the way up to 100." And it's like, whoa, um, no, like, if we went from 5 to 10 and we weren't under control, we need to talk, right? I mean, we need to figure out a plan. But so that whole concept, I think, really has changed. You don't see that anymore, nowhere near as much as you used to see anymore. Very rarely do you see uh, orders that kind of exceed 100% of their starting dose without, stopping. So I think that narrative really has changed. But I think from a perception perspective, still think you have families that really write a lot of stuff. I mean, on social, you still see it out there. They're very worried about stopping their meds. They're very worried about what hospice is going to do in those situations, and so I think those are things that we have to be cognitive of and navigate really carefully.
Yeah, I also think the misconception in hospice is and this was mine before I came into business. I thought when you went to hospice, you went to that ward at the hospital where you went there to pass away. It was a GIP scenario, and
Yeah.
most people don't understand that you can spend 180 days at home, have a great transition at the end of life, have nurses, chaplains, social workers, pharmacists, everybody coming in to see you and take care of you, and you can do that in your own home. And so I
That's right.
think that misconception is still out there. I mean, I still think the old school way of thinking of hospice was you went to a hospice house. I mean, I remember, my family, experiencing that. And we actually, took Nana to that ward in the hospital, which was a hospice house. And so I think that's one of the biggest misconceptions too. But I think around pharmacy, I think you're right on. It's, we're going to de-prescribe things that you don't need. We're not trying to do symptom control. We're trying to do symptom control. We're not trying to do healing. And we're just trying to make sure that Nana's doing it. I look at tons of patients in our Muse platform that are on 25, 30 meds twice a day. I mean, it's bizarre. And you start, if you nail out 5 or 6 meds and try to swallow all those, I mean, now you've got a bowl of cereal. I mean, Lily, you need a spoon and a, half gallon of milk in order to take all these medications. And
That's right.
that can't be good. But it's, everybody's ordered something for Nana to take care of that problem she had. And now here we are. I know you want to share your own story of how you found your way out here, but let's talk about some of the ways some of those, the patients that kind of got you in hospice, or tell us some stories.
Yeah. So I think, so a couple of things. I think, that journey, I think, was really important, right? Because that journey from, like all the way up through hospice, I think is important because there's pivotal piece in that journey, right? That kind of gets you to this story, right? And um, when you look at, like, we do these articles, we write these books, right? We do this education, right? I have been doing honestly, I was doing discontinuing medications in the life for 20 years ago as a topic of presentation. De-prescribing wasn't even a term yet at that point. And you look at milestones with hospice, right? And some of those milestones really kind of centered around um, this idea. So you had, I remember that, so I remember back, NHPCO didn't have a pharmacist section leader at that point, right? And so that pharmacist section leader had abruptly left, and they had a gap. And I remember stepping into that role for a year, and then I ended up running for their next term. And so I ended up doing 2 consecutive terms with NHPCO. So I ended up being the pharmacist section leader for NHPCO for 7 years, and working with them on a lot of different things. And so, I mean, if you look at all the stuff that, sort of happened regulatory wise, I mean, it's 2008, you had the new COPs that came out. That was the first time you really saw this, I think, conversation that medications needed to be part of the plan of care, right? And so you saw, that sort of happen. You saw, CR 8358, 10573. Now you got to put all the drug NDCs on everything. And so you saw the Medicare Part D stuff, right? You saw all those things that sort of came along. And so, my ability to sort of work with them and Medicare and really to put my fingerprints on all of that type of stuff, kind of really put me in that position over the years to somewhat kind of influence things. And so when I look at a story like this, right, I think back, right, because it's one of those pivotal moments in that journey of, like, where do we need to change things? And so the phone rang just one day, and I picked it up, right, like you do, like when the phone rings, you pick it up, and it was a nurse, and she was calling, and she had this patient, and he was one of those patients who really was just stable. He was stable. He was doing great. The wife was the caregiver. She was absolutely fabulous. She was like the ideal caregiver, right? She would write anything down. She would do anything you asked her to do. Like, she was the ideal caregiver. And I remember the nurse calling me and saying, "Hey, Mr. Jones, right, is having a bunch of uncontrolled pain and difficulty swallowing. This is new for him, right, because he had been so stable." And she had sort of said, "I'm on my way in the car to go see the wife." The wife had called and said that he was out of pain control and had anxiety for the last 2 days. And she said, "I'm on the way over there. Can you just peek at the profile? Tell me what I'm running into. Give me some, talking points or whatever. So when I walk in, I feel good about what's happening. and we'll go from there. So we talked a little bit. And, one of the things I stressed to her is we got to find out what the wife has given over the last 24 hours, right? So we can kind of figure out where we're at here. And so I said to her, I said, I said, why don't you, if you need to call me back, I said, we can always go on speakerphone with the wife. I mean, whatever you need, right? I said, but get there, assess the situation, and go from there. So my phone rang a little bit later, and she was there. She was like, we've got, I got him some pain meds, and she said, and I have the wife here, and let's talk. And the wife was, at this point, was beside herself. I mean, she was really, you could tell that the last 48 hours of her, journey had been rough, right? And so we kind of, sort of tiptoed to the situation and sort of said, hey, you've got all these things. You do such a great job. Can you give me a little bit of an idea about what medications you given in the last 24 hours? And she said, so I said, how much morphine have you given him? And she said, none. And I was like, okay. And so I was like, well, what about lorazepam, right? And so I'm thinking to myself, I'm on the phone right at this point, right? So it's easy for me to like drop my jaw and be like, oh, the nurse is sitting in the home, sitting there, that'll probably like, oh my gosh, what is happening at this point? And so I asked about lorazepam. I was like, maybe she's using lorazepam instead. So I asked her, she's like, I've given none. And so at that moment, right, I knew something's weird, something's going on here. And so I say to her, okay, well, tell me what happens. Like, tell me your day, like what's going on. And she's like, look, I start the day, I try to give him breakfast in the morning. And she was like, normally that takes like 20, 30 minutes. And she said, because of the difficulty swallowing the last couple of days, it's been like 3 hours. And by the time I get done with that, he's exhausted. I'm exhausted. I fight with it. I'm having to crush everything. I'm having to, put everything in applesauce and pudding. The whole thing is falling apart. And I said, so when you start this journey about medications, I said, where do you start? And this is where the story fell apart, because what she says is, she goes, well, the first thing I start with is the multivitamin. And she said, I've gone through, and she got real strong and real emotional at this point. And she said, I've gone through about 50 of these pills. I've split them. I've crushed them. They fly over the floor. She was like, I've been on my hands and knees picking up little pieces of white stuff all over the place. And she was like, these things just can't be crushed. And I put him in this applesauce and he spits it out. And then I have to go crush another one. And she was like, I spent 4 hours trying to give him this multivitamin yesterday, and I'm just through. And at that point, right, I knew at that point we failed. We failed her. We failed him. We failed the entire process, because she, being this wonderful caregiver who does anything you ever ask for, or writes everything down, is sitting here having this long conversation about how she felt like this vitamin was still important. And I just feel like it was a failure. It was a failure on us that we ever got to a point where she didn't feel, where she felt the need to still give that multivitamin. And I think sometimes this story sort of resonates in the fact that sometimes when everything's going okay, we don't have the conversation. When things are really rough and we're having it's easy to walk in and say, you're in a pain crisis or whatever. I'm going to stop these 3 meds. I'm going to start these 3 meds. But when everything's going right, we don't. And back then, when this happened, de-prescribing wasn't a term, right? We talked about discontinuing meds, but de-prescribing wasn't even a term that was in the medical community. And I remember that was a turning point for us, because we said to ourselves, we have to teach people how to stop meds. And we started, we whiteboarded. I still remember sitting in the conference room with the whiteboard. And I remember us writing all these things like, what do we got to do to teach somebody how to stop med? And I remember looking at it, and we actually ended up coming up with the build model, BUILD. And we published that build model, and it was how to have conversations with patients about stopping medications at end of life. And that was sort of the beginning process of, there needs to be formality around this. There has to be structure around this. Like, you have to learn how to have these conversations. And I think that piece is so important. Because like you said, it's not necessarily just about cost, right? I mean, it's about the fact that you walk in, you said, you look at Muse or whatever, and they have 25 meds. I mean, it's a cereal bowl, right? I mean, and so on one hand, it's like you want to walk in the door, you want to, they pour the bag on the table, you want to look at it, you just want to start picking them up and saying, this is worthless at this point, this is worthless at this point, get rid of this, right? You just want to kind of go through that. And the reality is that, you can't do that, right? I mean, you can't walk in. I mean, that physician has told that patient, you're going to take this cholesterol medication because if you don't, right, you're going to have a heart attack or something, right? And so, like, they've been ingrained for the last 5, 7, 10 years that they need to take this. And if you just walk in the door and just say, that's not needed anymore, right? I mean, you don't really create a good environment for them to really believe you or to understand. And so, that story was one of those pivotal moments right along that timeline that sort of said, we really need to talk about de-prescribing. So it's fun because now when you hear about de-prescribing or you hear hospices and they're like, we have a de-prescribing initiative, I sit back and I say, it started. Nobody was talking
Finally.
about de-prescribing. It started with that patient who couldn't swallow the vitamin when we started all talking about we have to do a better job of being proactive and talking about discontinuing medication.
Yeah, I remember when you told me that story. I actually went home and pulled out a couple of different multivitamins and tried to crush them just to see. And I had them between. I think I might be one of the strongest guys with hands in this industry, and literally I had 2 spoons together trying to crush this vitamin. They're really hard, and
Yeah.
I can imagine that poor lady doing that. Education is a big piece of that. I have to tell a story here. When I was a corpsman in the Navy, a Marine came in. He was super sick, and he was a Lance Corporal from Louisiana. And the kid was bad fever. He had the flu really bad. He was sick, couldn't hold anything down, nausea, vomiting. So I gave him some Tylenol suppositories. And, education is everything. And so I give this kid this Tylenol suppositories. And next morning he comes back in for a recheck. He's like, Doc, these things are killing me, man. They don't work. And I'm like, what do you mean they don't work? He's like, I can't swallow them. They're like I just can't swallow them. And I'm like, what do you mean swallow? You don't know what to do with a suppository? Nobody, I never thought to tell him that, right? I mean, it's said on the instructions. He didn't read the instructions. He's pulling out a suppository, trying to eat it and swallow it. He couldn't get it to go down. And I'm like, it's like waxy and it dissolves in your mouth. Yeah. And I'm like, oh man, we failed, right? We should have told him how to take the medication.
Exactly.
I'm like, hey, here's some Tylenol suppositories. Take these, come back tomorrow. I mean, he's still had high fever. So there you go, your education. But also you got to remember that sometimes Marines aren't, he was from rural, backwoods Louisiana. He never even heard the word suppository before. And my assumption is he knew what it was. So I was wrong and I failed. That's awesome. Thanks for sharing the story. And that poor lady with the vitamins, I just feel sorry for her. I can imagine the pain she's going through. And we should have, what's a vitamin going to do to a hospice patient who's dying?
Yeah, a lot of the things, that's the most important thing I think out of all of it is that so much of what we do, right, is to prevent or to delay or to change the outcome of something long down the road, right? And so if I'm taking vitamins, I'm hoping to, if I'm not looking to take a vitamin to change the supplement portion of it, right? Like I'm not getting enough vitamin A in my diet type of thing, which is pretty rare in most of this part of the world, right? That you don't have enough vitamins from diet or whatever. But I mean, really, you're talking about, hopefully I'm trying to prevent something from happening. And when you look at hospice, obviously, your timeline is sort of set at that 6-month line, right? And so you're kind of looking at everything through that lens. And long outcomes of I'm going to hopefully prevent you from having a stroke 10 years from now becomes very different, when you start looking at it to say, I'm going to prevent you from having a stroke. What's that going to look like in the next 6 months?
That's right. Which medications or classes of drugs are most misunderstood in hospice?
I don't know that there's necessarily one class that's misunderstood. I mean, I think for the most part, and I guess, I mean, are you looking at it from the lens of the hospice professionals, or are you looking at it from the lens of the patient?
Yeah, yeah. Let's do both. I mean, let's look at it from the
Yeah.
hospice professional, and and I always like to tell everybody that when you're a hospice nurse out in the field, I mean, you have a doctor you have a medical director that's around you, but you're by yourself in that patient's home, and you're trying to make decisions, and that's where these pharmacy solutions that are out in the industry are really important, right? They're doing a medication reconciliation. They're there for you as a nurse, as your resource. I mean, if you're in a hospital and you have a pharmacy question, you just call the pharmacist and boom, they're right there. They come down to the ER, or they come down to the ICU, they help you. They're all over the hospital. But if you're out in the field and in rural Tennessee or rural Texas, and you're on your own, you're a phone call away. And so that's why, I think it's super important, one, to engage your hospice pharmacy and make sure you're de-prescribing when appropriate, but also making sure you understand most of these nurses haven't, they had a little bit of pharmacology in their school, and they used to carry the PDR with them. Now they have it electronically, I hope. But, having that expert right there beside you can be super valuable. So, um, yeah, so let's talk about from the nursing perspective, which ones are misclassified or hardest to deal with. And then let's talk about from a patient perspective.
Yeah. So I think from a nursing perspective, I think that the challenges, right, really are looking more at using some of the medications we probably use that are maybe a little bit more unconventional, right? I mean, like we use haloperidol for nausea a lot, right? And so if you walked into the hospital and you said, "Oh, somebody's got some, nausea, let's use some haloperidol," like I mean, they would look at you like you have two heads. Like it wouldn't even come across for them. And so, I think the challenge for nurses, and I think you are 150,000% correct. I mean, if you look at the average time in hospice for nurses 10, 15 years ago, it was like 8 to 10 years. If you look at what it is now, it's like the average experience in hospice is like 2. And so the challenge, right, is that we have a lot of hospices nurses that are in the space that are fresh out of school. They're coming from an ICU, they might be coming from the ER, they might be coming from pediatrics, and now we're putting them out in the house, right? And we're saying, "Oh, by the way, good luck. Let's go take care of all this. You need to manage everything with the patient, figure out what's going on with them, right? You need to manage their meds, you got to manage their DME, you got to manage their medical supplies, you got to do it all, right?" And so, hopefully you'll get right. It's a little bit how it kind of feels, right? And so, I think when you show up in hospice, and I think the way that hospice professionals who have been doing it for a long time look at it, and they sort of say to yourself, I want to get down to 1 to 2 to 3 meds. And I want them to be able to do as many things as possible. So if I'm going to use haloperidol for nausea, it's because I can manage nausea, I can manage agitation, I can do terminal restlessness. I can manage, lorazepam can help me with shortness of breath and anxiety. Morphine can help me with pain and shortness of breath. I want to get down to the brass tacks of what are the 3 or 4 things that can get me the most bang for my buck. And then, oh, by the way, can I get those 3 or 4 things into the person, right? Are they crushable? Are they in a liquid? Can I give them rectally? Are they available for sub-Q administration? Like that's the way that you look at it. And I think from a nursing perspective, you know, everything that they've been taught up until this point really has been use the medication that's first line therapy, right? Maybe in the hospital or what was taught in the book or whatever. But at that situation, if we did that for every one of these patient scenarios, we'd end up with you know 17 meds upon admission just for comfort, right? Because we would give all these different things. And so I think for nurses, it's not necessarily about the drug class per se. I think more it's about understanding and trying to really navigate the whole, how does everything change? Like how do I look at what I'm supposed to give in this situation, and how am I supposed to use it? I think from a patient perspective or a family perspective, I think it kind of ties back into what we talked about earlier. I think there's a lot of fear, with opioids. I think there's a lot of fear with um, benzodiazepines. I think there's a lot of fear with all of those things because from a society perspective, right? I mean, just think about it from a society perspective. If I walked down the road and I polled a bunch of people and I said to them, "Hey, what do you think about Xanax? What do you think about methadone?" Right? I mean, what do you initially think of? Drug addict.
Right.
I mean, that's what you hear about. You're like, oh, well, the drug addicts use methadone clinics and stuff like that. So when I walk in and I say, oh, let's manage your, your pain with methadone, or let's manage your pain with lorazepam or whatever. I mean, it to some patients, that's a shock. That's a big deal because, like, I'm not a drug addict. Why? How dare you come in here and talk about methadone? When I look at methadone, I look at it from the fact is that here's an opioid that is it's the only long-acting opioid that I can crush that comes in a liquid form that I can give rectally, right? I can do anything I want with it, right? Oh, by the way, I can get away sometimes with once or twice daily dosing, so it has long half-life, right? Oh, by the way, it's the only one that treats nociceptive and nerve pain. So now I can get to two types of pain, right, with it. And so I look at it for all these valuable things that it has with it, right? And oh, by the way, it's one of the opioids that causes the least amount of sedation. And my goal from a hospice perspective, right, is to have you be as alert as you want to be, right? Whatever your goals are on your journey, right? If that's to be engaged or be able to go out to the garage and work, at the wood shop or whatever it is that you want to do, right? I want you to be able to feel like you can do those things, right? And sedation obviously is a concern with opioids. And so, methadone causes some of the least sedation. So I think when you start to look at these stories, you find that there's like hospice is like the perfect example of something has two sides to a coin, right? Because you say something like methadone, and immediately the conversation turns to that's a drug addict use, right? Why would I ever use that? And then I flip the coin on you and say, look at all these amazing things and why you'd want to take it for hospice. And then you're kind of like now sitting there saying, well, gosh, why wouldn't everybody use methadone? and, and then you realize you come back to reality, and you're sitting there saying to yourself, well, but this patient has 6 months to live. And we're not talking about a patient who has, 15 years or 20 years to live in their life. Like, you have to handle things so very differently at this point. And so I have always said for a long time, pharmacy can be super, super fun in hospice because you can actually use medications to treat things how the best way that you can without having to worry about all that other stuff. I always say we give out benzodiazepines like they're Pez candy sometimes. We give out steroids like they're Pez candy. Again, I can't come, to you and say, hey, let's put you on, dexamethasone for the next 12 years or whatever, because you're going to have all the long-term side effects of steroids. But I can guarantee you that if you had some sort of pain or, lung disease or something like that, I mean, you probably would take steroids if they didn't have long-term side effects because they work a lot better. And so, I think hospice kind of gives us the ability to use meds for how they were, intended to be used without having to worry about long-term side effects, which is kind of unique.
HCHB is proud to sponsor the Last Visit First podcast, which explores the complex issues faced by today's home health and hospice providers.
In the spotlight today, Chief Revenue Officer Hannah Pearson, explaining how HCHB uses technology to connect people.
One of my favorite phrases is relationship architect. The focus is about the client and building the right community, the right fabric of community around our customers, making sure that from the very bottom to the very top, they had a resource and a contact to reach out to with any problems, and that we could connect them quickly and expeditiously to the right resource. That's where the client success team was born, and we touch people at every level of the organization.
All right, let's jump over to policy. So CMS rules, cost pressures. Where do you see hospice pharmacy spending headed?
Yeah. So, I mean, you kind of got, if you look back over the last couple of, handful of years, you kind of got pounded from a hospice perspective, right? I mean, that whole Medicare Part D leakage sort of understanding, that turn that you saw with CMS, where we're not going to talk about related to the diagnosis, we're going to talk about related to the prognosis. And then you saw, the conversations that came out where it was pretty much, we don't believe anything is not related to the hospice prognosis. We're having a really hard time finding any example of anything that wouldn't be related to the hospice prognosis. It really was a big shock to the industry. I mean, such a big shock. I remember when Medicare Part D had the call letter that came out that basically said, hey, if the TRC comes across on the TR that says they enrolled in the hospice, go ahead and turn off their Med D plan. And like everything started to reject at that point. I remember having to try to navigate those relationships, right? I mean, and of course I was the pharmacist and I was on the hospice side of it, right? So, for me, it was advocating for hospice and talking about what hospice, needed to, what they needed to understand about hospice. So we could sort of peel back some of those rules and some of that drama that it caused. But that sort of shined a spotlight, I think, from a regulatory perspective on hospice and where the spend was. And I think you sort of saw the path, and it sort of started to lead down this conversation of, is Medicare Part A fee for service where we really want to be? Is this better for this to be a Medicare Advantage plan? Should we do a carve-in? Like, is it better just to sort of have that all pushed over to Medicare Advantage and let Medicare Advantage handle it? And I think from a hospice perspective, I always said, whatever you do, you have to keep it a bundled solution. If you try to unbundle this scenario and you send it to Medicare Advantage in an unbundled world, can you just imagine what the response would be? You talk about, now I'm going to go into Mary Smith's house, and now she has a Medicare Advantage plan with X, Y, and Z, and now I have to know that she has these drugs on the formulary, and I can only use these drugs. And then I have to go down the street and with, Bobby Joe, and Bobby Joe's got another Medicare Advantage who has a completely different formula. Hospices would fall apart. It would never be able to get the therapies that they needed. And so a lot of the conversation about pharmacy and unbundling was really pressured around, like, if you're going to do a carve-in, you're going to do the VBID, obviously, trial, it had to be a bundled solution. Like, you can't tear this thing apart. So, interesting, like VBID didn't really sort of pan out. A lot of people sort of jumped out of it. I know that there, obviously it was, pulled back on. I still think there's pressure there. I still think the dynamic still is happening. Medicare is slowly continuing to watch how much Medicare Part D leakage there is, how much hospice spend is coming to Medicare Part D plans. You can see Medicare Part D plans are constantly sending out recoupment letters, right, and trying to recoup that money from hospices. It's still, the world hasn't settled yet in that space on how they want to handle that. And I think hospices need to understand that if the leakage continues to happen and the billing continues to happen in those scenarios, it only sheds the light on the Medicare Part D providers sitting at the table saying, look at all this data of all the things that hospice didn't buy. And every time they do that, it shines the light on hospice at that table. And I always just kind of envision, like, it's not really a table, but like if you had them all sitting around a table talking about it, it'd be hard pressed for me to sort of say, here's this long list, Tom, of all these meds that, millions and millions of dollars that hospice, kind of punted right off to somebody, but yet you want to come to me and ask me for higher reimbursement rates. Like, it would immediately kind of create that sort of dynamic where somebody looks at you and says, why would I pay you more? I just got like an invoice of, millions and millions, hundreds of millions of dollars of drug spend that you didn't pay for. So it's a challenge. I think hospices, I've always said that the value of hospices adopting a de-prescribing initiative is that if you de-prescribe it, there's nobody to bill it to. And so the billing problem resolves itself. And so if you can adopt a education first, a de-prescribing model, right, you can then start to figure out how to absorb that cost of maybe having to pay for some of those more expensive meds that maybe you shouldn't punted to a Medicare Part D plan if you do that. But if you don't adapt that strategy, then your costs skyrocket, and then hospices are looking at that as an expense that's worrisome. So I think regulatory wise that conversation's still spinning right now, even with the Medicare Advantage sort of carve-in pullback that sort of happened, but I don't think it's dead.
Yeah, I mean, I think you and I had a conversation a few years ago about, the same patient that had a nebulizer in her home and oxygen and all that was ordering bundles and bundles of inhalers too. Same med, same information. and the cost on an inhaler is just a crazy amount of money compared to a nebulizer in the home. And it's just really bizarre. And you start looking at that, and I mean, I know we were talking about putting Muse together with, pharmacy and saying, hey, how do we, if we know a patient's on their, last days of life, why are we ordering 60 days worth of opioids, or are we ordering a box of inhalers, or why are we ordering all these other medications? Let's be strategic in how we do it, especially for the accuracy of some of the tools that we have. That's cool.
Flip that conversation to when you look at it and you see that the hospice paid for the nebulizer but didn't pay for the inhaler for the same disease. How do you argue that, right? I mean, it's really hard to sit back and sit there and say, well, and now it turns into, well, it was expensive, so I didn't want to pay for it. And then it turns into, it wasn't on my formulary, so I didn't want to pay for it. And, and CMS's response have been very clear on both of those things. Your formulary, you're allowed to have formulary, but it does not drive what you pay for. You pay for what is related to the prognosis. The formulary is just a tool. And nothing in the Medicare hospice benefit or the conditions of participation state anything that says that you cover things like medications for the pain and symptom management, but only things that are cheap. Right. And so it doesn't say that anywhere in the COP. So when you look at it from a data perspective, and I think people have to just remember that a lot of times when this is sort of being looked at, it's not being looked at by this high level clinician who wants to have this conversation. It's being looked at by an analyst group. Right. And so they're looking at this data. And so you see it and they say, on one hand, I see you submitted a nebulizer on your claim because I got this drug on your hospice claim, and I see Part D got the. So why did you buy the $13 inhaler, and why did Medicare Part D buy the $350 Advair or something like that? And it sends the wrong message. It sends the wrong message. It's hard to argue too.
Yeah, let's talk about that. So one of the things that as a consulting company that we deal with a lot is the formulary, and how to strategize for us as the guy that was on the other side of the fence, and you were at one time for years and years, and now you're in the consulting world. What's the right way, best way, most convenient way to manage your formulary, and how often should you look at it? Is there secret sauce there you can share with the audience, Jason, around dealing with this formulary, especially if I'm a CEO, maybe I'm not a clinician, and now I have all these, different vendors coming to me to manage my formulary. What's the secret sauce there? How would you do it if you owned a hospice, I guess?
Yeah, well, and it's hard to, so in general, right, I would say that from a formulary perspective, you should be looking at a formulary perspective from the standpoint of if all things are equal, right, I should be able to write a formulary that has the medications that are appropriate for patients at end of life, right? And so those formularies need to somewhat have and be driven by quality of care, right? And that's the first step, right? And then the second step, sort of, it's hard to unbundle that from a pricing structure, right? Because that's where it gets to be a little funky, right? If you're a hospice leader and you're looking at this, and I think if you look back, oh gosh, probably, I don't know, 15 years or so ago, right? I mean, hospice leaders had that ability, I think, to somewhat they had kind of a yes and no decision, I think, when they looked at pharmacy, right? Pharmacy was kind of that, do I want to be in a capitated per diem model where I have this drug list and I pay this per diem to have access to it, right? And then anything outside of that I have to pay for, but I'm going to do that. And then I had this model over here, which was very much I'm going to buy, it's fee for service. I'm going to pay for what I buy. And that was really the decision. Right. And I think that mindset, right, is important, because if you're looking at the left side and you're looking at a per diem and you're looking at a formulary, right, it becomes vitally important, right, that your formulary, I mean, anything you buy not on the formulary obviously costs you more than what your per diem is. So now you're getting into the whole conversation about who's underwriting that formulary, right? What's that formulary? Who is going to win in that formulary? Because, like, at some point, right, the pharmacy obviously has to make money too. And so that formulary becomes an interesting conversation in that world. In a fee-for-service world, if you don't follow a formulary, you just buy what you use, but you go crazy and just buy all kinds of stuff, then your spend is really high. So I think back in the day, those were choices that hospice leadership had to make. And I think when you you saw the milestones in the timeline, when you saw the CR 8358 10573 come out, and that was the first time Medicare said, I need you to report to me every NDC, every injectable, every HCPCS code, what you paid for it. I want you to put it on the claim. That introduced a concept, right? Because now all of a sudden you had Medicare coming back and saying, well, wait a second. Why did this hospice pay $0 for all these meds? Why did this hospice pay $500 for Tylenol? Right. And so you had this innate, interesting conversation where it was like, yes, you're supposed to use this per diem capitated rate, for the most important part, but you're using it now for, $500 Tylenol. What are you doing? But they really weren't paying $500. It was because it was part of a per diem. And so the calculations were wrong. And that generated a lot of noise. And so you started to see all these others like spin out models, right, that came out of that. And you started to see a lot of pressure from vendors of, my model's better than this and you should use this. The thing I would say to hospice leadership is, it doesn't have to be that hard. It really doesn't. Frankly, right, I can show you how any model can beat any other model, right? And so I can show you how a fee-for-service can beat a per diem. I can show you how a per diem can beat a pass-through. I can show you how a pass-through can beat a per diem. Like, I can show you how any of those models can beat each other, right? From a mathematical perspective. I think the most important thing from a hospice leadership perspective, right, is that they need to kind of take back a little bit. I think they lost a little bit. Before, it was kind of like, do I want a per diem or do I want fee-for-service? Now I'll go to those vendors. Now it's kind of like, I'm not really sure how to navigate the water real well, and everybody's telling me theirs is the best. And I think hospice leadership has to step back a little bit from that and say, I need to understand what is happening here. Because if I don't understand what's happening here, they can't pick the model that's for them. And I'll give you a great example. If you're a hospice leader and you're looking at trying to do more open access sort of things, and you want to sort of pay for, chemo, or you want to pay for, dobutamine infusions, and you want to do those type of things, like, there are going to be certain models that are going to be, that's going to be really painful for you to do, right, if you go into that sort of situation. So I think really it's about hospice probably learning a little bit more about what those models sort of bring. And instead of letting the pharmacy vendors always tell them what's best, they need to somewhat understand what's going to be best for their structure so that they can find the right vendor who actually, probably finds the right model that's going to help them get that cost containment. And so I think if you're in that wrong model, right, and there's probably money left on the table for you.
Yeah. All right. That was awesome. And you know this stuff better than anybody. So I know we come to you for everything. How often should I look at that? Is it twice a year, once a year, every 5 years?
No, I mean, you should look at your formula. I mean, hospice leadership should be looking at their formulary utilization, obviously, monthly and quarterly, to see how they're tracking against it. But as far as an overall, I would say yearly would be a good factor. A lot of times you won't find a lot of changes that need to happen, but I mean, yearly should be, if you look at it month over month or quarter over quarter, you start to see deviations. You need to understand that. And you don't want it to get so far away. But I mean, from a hospice leadership, yearly is good. From a pharmacy management perspective, they should be looking at it quarterly with you. Like, they should be looking, because I mean, you want to make sure that there's, any new drugs or changes in pricings. If all of a sudden, something becomes generic and and the price goes down, you want to be able to move that around. So from a pharmacy angle, it should be at least quarterly. From a hospice leadership perspective, it would say yearly is a good spot to be at.
Yeah, I agree with that. But you need to track your pharmacy spend on a monthly basis. And
Yes, pharmacy spend for sure. You need to track all of this on a monthly basis. You'll just find that probably month over month, your formulary utilization would be 92%, 92%, 91.8%, 2.3%. Like, you'll see that it kind of stays the same. I mean, if you're tracking your formulary utilization, it's 58%, you have a problem. Like, it should be 90% north.
Yeah, or you have the wrong formulary.
Correct.
There was a lot of scenarios back in my and Clara days and your Optum days where drugs were unavailable, especially during COVID. We had a bunch of this, and thoughts around that, like those are going to continue to happen to us, where all of a sudden this really popular forward-looking medication that we're always using in hospice becomes unavailable in the form that we need it. And so we're scrambling, and I know I've spent many days scrambling. I know you have as well. Any thoughts around how to manage those scenarios easier, better, faster without stockpiling a whole bunch of medications in a back room?
No, I mean there's a stockpiling strategy, obviously, that does come forward with that, and so you definitely want to make sure you have that. But I mean, really, honestly, it's about being nimble. Like I think for the most part, you can do a lot of stuff. But everybody has to be open to that, right? I mean, like it's like, well, I can't get lorazepam liquid, and I don't want the tablets or whatever. So like, I feel like I'm stuck with injectable or whatever. Then you have to be okay with sub Q. Like I always say that like you've got to the comfort level of the staff has to be okay with any of the routes of administration for any given patient at any given time. Now, how likely will you use subcutaneous meds in the home is probably pretty low, but it shows up on a regular basis. But if the knee-jerk reaction from everybody in the organization is we don't do that, or we're too scared to do that, or the nurses, state that we've never done that before, that's a problem. And it's a problem when the shortage happens at that moment because now you're in crisis. And so um I would always encourage everybody to sort of say, what would you do if you didn't have this? Like, what's you run through all these, scenarios, right? I mean, crisis scenarios. It's like, what if all of a sudden morphine went away? What would you do? What all of a sudden if you didn't have this and, you only had to use injectables and like, what would you do? Like, do you have a policy on subcutaneous meds? Do you know which meds can be used subcutaneously? Would your staff be comfortable using subcutaneous meds in the home? Like, and if the answer to those questions all of a sudden become no, I would never do that, then you run the risk that when the patient is in crisis, now we're having to try to confront that.
And that's usually when policies are made, and then I wouldn't say that they're the best policies that are made. When we're in a crisis now, we have to spin, we have to change, we have to
Yeah.
figure out how to make sure people have a subcutaneous policy, or whether it's the Macy catheter, and have you used one before, and now it's a liquid, and how do we use that? So yeah, but there are these scenarios, and you and I have both experienced them where the medication's not available for whether it's the formulary of that, or the formula, not the formulary, but the formula of that medication is, bought offshore somewhere and we can't get it, or there's a crisis, or it's, I think at one time there was a fire somewhere that caught one of the labs on fire, and they couldn't produce the medication. We were like, okay, what do we do now? And so we were having to go to, these local pharmacies to, mix the meds or compound the medications for us. And it caused a lot more challenges. Let's talk about hope, a little bit about hope. And I said there's still hope in hospice, but now there's really hope in hospice. What do you think have you heard anything about how it's going, where it's at? I mean, I know there's a lot of noise on the bulletin boards today around, lots of things are being rejected. They can't get their hope assessments to go through the process. But your opinion on, the hope measures and how they're being implemented?
Yeah, I mean, I think for the most part, I mean, I, I think if you break it down, right, and from a structural perspective, right, I think hope is new, right? It's a new rule. Anytime you have new rules, new regulations, those type of things, right? You're in that situation where you're kind of relying on like how do the systems work, and obviously let's face it. I mean, change is hard for a lot of folks, and change is hard even in hospice in general, right? And so I think, I mean, I've heard the same things probably that you've heard. I mean, there's struggles, documentation doesn't work, or things aren't flowing right, and those type of things. I think overall, the idea behind it, right, is good. I mean, I think the idea behind trying to move those things, uh, try to move those engagements from symptom management when patients have uncontrolled symptoms, how you're getting back out there and how you're documenting it. How I think it puts back into the forefront what hospice was all about, right? Is to sort of provide that comfort, and so it's putting that documentation and that structure sort of around it. I think people will adapt to it just fine. I think at the end of the day, and I'm sure that the technology bugs will all be worked out, right? I mean, but I think it creates opportunity. I think it creates good opportunity to manage it. And I think, just like anything else, sometimes regulations force the hand to do different things. And I think it's going to force the hand to sort of ask ourselves, do we really have the structure in place to be able to manage these symptoms? I mean, are we, when we have to go back out and we're expected to, show results from this, and we're not getting results. what are we doing? Is it a byproduct of us not having the right pharmacy experience? Is it a byproduct of us not having the right clinical education? Is it a byproduct of not using the drugs really well because, we don't really understand them? I think all those things sort of show their head, right, when you start to point a spotlight on this. And so, again, I always go back to, what is it we're here and why are we doing it? Um, that sort of picks the meds and the choices that we make. And so, I mean, I think it's a good thing overall. I think there's going to be challenges with it.
And I think pharmacy is going to play a big part of it. I mean, if you think about, the 8 big factors: constipation, dehydration, pain, anxiety, respiratory dyspnea, those kind of things, all those are pharmacy related, right? I mean, all those are how do we manage, to the patient, but also, it's just super interesting that CMS said that, a lot of these follow-up visits have to be done by an RN, can't be done by an LVN. So it may change the staffing model for a lot of hospices. It's going to require you to do more visits. I think in my, gut feeling is that that's what CMS wanted. If you're having problems with dehydration, they want you to go back out and see the patient, in the next 2 days and make sure they got dehydrated and we solve that problem. If not, they're going to decline faster. And so it's the first time we've really had a standardized assessment in hospice. And for years, home care, home base, I'd talk about, the OASIS and the standardized OASIS assessment. And every time I did that in front of a hospice nurse, she'd just roll her eyes at me like, "You're a home health guy, aren't you?" And I'm like, "No, I'm both." But they used to get really mad at me. I've been yelled at a lot, but people are like, "We don't do those in home care or in hospice. Quit talking about home health." And I'm like, "You will someday." And unfortunately, you will. And it's here.
Hi, I'm Jennifer Maxwell, CEO and co-founder of Maxwell Tech. Here at Maxwell Tech, we believe mergers and acquisitions are not just financial events. They're clinical, operational, and regulatory transformations that ultimately determine whether a deal succeeds or fails. In home health, hospice, and post-acute care, too many transactions underperform, not because of the evaluation, but because leaders lacked clear clinical and data-driven insights into what they were actually acquiring. Here, Maxwell Tech supports buyers, sellers, investors, and boards across the entire M&A cycle. Over the past decade, our team has supported hundreds of diligence processes, including platform acquisitions, tuck-ins, carve-outs, and multi-state roll-ups. That depth of experience creates true pattern recognition. We know what normal looks like, and we know when the risk is hiding in plain sight. From the first touch to the last visit, Maxwell Tech helps M&A strategies actually work. If you're preparing for a transaction, in an active diligence, or navigating post-acute close integration and want clarity grounded in real clinical and operational data, now is the time to engage. Visit maxwelltech.com or email us at sales@maxwelltech.com to start the conversation before risk becomes reality.
Hey, what role should a pharmacist play in IDT?
I think, I've always personally been a little sad, when I see the graphics sometimes that show up and say, these are the members of IDT, and there's not a pharmacist on there. But, I also can appreciate and understand that, a pharmacist is, typically not there, right? Now, granted, for years and years and years, right? I mean, I went to interdisciplinary team every week. So, with my local hospice, I would go to interdisciplinary team every week. I would go round in the IPU. I would go out and do home visits with the staff. And so, I did all of those things, right? And so, and I think that creates an experience, right? Because if you're in IDG, if you're in the rounds, if you're going into the homes and you're doing those visits, then it's easy for you to understand. Now, I might not do them 12 a day, right? And, and I might not go that many times, every single day or whatever, but it's not like I've never been in those situations. So, it does help me kind of appreciate and understand like how everything works, right? And and how you have those conversations. So I think as far as the pharmacist role, right, I think it needs to be, that when you look at the medication plan of care, right, you have to get to a point, one, I think mentally you have to get to a point where you're looking at those meds and you're sort of saying like, I think one of my main tools, right, for this entire patient experience is meds. Like that's like, I'm going to be using that a lot. And so I think you need to constantly be thinking to yourself, when I look at those meds on that sheet and that EMR, right? I'm looking at it, I'm saying to myself, like, what would Jason want me to do here, right? I mean, like, you have to almost think like that, because I won't be there, right? Or that pharmacist that you have might not necessarily be there every single time. So I think you have to create a dynamic where you are thinking about it in that mindset of that you want that to somewhat happen. I also think at this point, right, I think with technology, the advancement, AI, um, seems to be all the buzz, of everything. Um, I do think that there is a component here that needs to be looked at, right? When you start to think about trying to figure out, how do I how do I supplement sort of that education, right? How do I bring forward sort of that idea of, pharmacy and that product? And so I know, clinicians obviously, a lot of clinicians are kind of a little concerned about AI. You see a lot of commentary about, like, I don't want AI to take my job. I don't want AI to tell me what to do, right? You sort of see that stuff. And I think, AI from an intelligence perspective, right, is very, very smart, right? From an emotional sort of quotient perspective, I think it doesn't have anything that really is valuable there. I mean, I think I was telling you a story a couple of weeks ago. We were talking how I was using AI for something, and AI was telling me that, like, there was no way that I could use this med hospice for this, and I was like, "What? That's totally wrong, right?" So I think folks are concerned about those things. I think I think I think we have a real opportunity at this point to bring the pharmacists in more into IDG. And of course, there aren't enough hospice pharmacists available in the entire country to be able to bring everyone into IDG. So when we look at it from that perspective and say, I can't attend, even if I wanted to, I couldn't attend every IDG. I mean, I can't sit on the phone for 12 hours a day just in 12 different IDGs. And if I did that, I'd only have 12 IDGs under my plate for the entire day. And there's thousands that are happening all at the same moment, right? And so I think we have an opportunity at this point, and I think that's a real opportunity from a technology perspective, is to bring forward the pharmacist into the IDG. And I think the only way to do that is through technology. And I think that
Yeah.
that to me is where I think we can make an inroad. And I think that that's where we can really help, because if you think about it, right, that nurse experience that we talked about earlier, right, has gone down so much. And so, now I have a nurse, they're on an island by themselves. We've pushed them out into the home. They have 2 years of, less than 2 years of hospice experience, right? They haven't even seen all this craziness, right? And now you're expecting them to somewhat manage through this. And, I don't know that I can get a hold of a physician instantaneously. I don't know that I can get a hold of, like, and so how do we supplement that? What I've tried to say is that we need to figure out how to amplify their experience. Like, we need to be able to give them those tools right there, kind of in workflow, where they can sort of help their situation. And I don't think AI solves that necessarily, and I don't think clinicians want AI for that. I think clinicians want um, more of an experience that's going to help them and engage in that scenario. And I think AI shines a light on the fact that there's a technology opportunity, but it doesn't necessarily involve AI. And I'll share one scenario, I think, because you look at somebody like with glioblastoma, right? And we manage them typically in hospice when they've stopped treatments. We manage them with dexamethasone, right? And so if you look at dexamethasone, right, this is a good example where, I mean, you might have, a ton of patients on for dementia and congestive heart failure and, lung cancer or whatever. But, like, how often does the glioblastoma show up on your hospice? I mean, you might not have any this month on service with glioblastoma. So, like, use that one example as a scenario and sort of say to yourself, okay, so what happens today? So what I generally see happen today, right, is that the patient, let's say, the husband has the glioblastoma, the wife and the kids are in the home. He's going to get mental status changes. He's going to, maybe his personality might change. He might get real aggressive. He might start swearing a bunch, and you'll increase the dexamethasone. So you'll go from 8 to 12, and then he'll get some mental clarity, right? And he'll get a little bit better. and then he'll get bad again. And then the wife will say, well, let's give him some more dexamethasone. And then we'll go from, 12 to 16. Right. And then we'll play this game. Right. And then the wife will call up and say he's, mentally, he's having a rough time again. And that's when we show up and say, yeah, we can't really increase the dexamethasone anymore. And that's the wrong time, because he's in crisis, she's in crisis, and we're now telling her that the plan that she sort of has kind of lived and died by for the last, couple of months here, which was to increase the dexamethasone each time, is all of a sudden not the plan anymore. And I think that's a scenario where you look at it and say, we should have intervened way up front. Just like the de-prescribing scenario, we should have been having a conversation with her about what does it look like? What are we measuring? What's the timelines look like for dexamethasone, when we would and would not increase it anymore? And I think you can lay that type of stuff out with technology. I think you can show people the roadmaps for those things to help them understand it and to be able to communicate those scenarios and help them work through those. And I think that's an example where I think it's one that gets missed. And I think if we put that in front of folks and showed them that and teach them that, nobody wants to meet the wife at the fork in the road when we stand on the one side and say, you can't go to the right anymore, you have to go to the left, right? Nobody wants to do that. I'd rather be in a conversation where we've talked to the wife multiple times about this, and I want her to be at that point where she sort of has understands it. So she might not be at a place where she accepts it, but she understands it, and the conversation sort of turns to, I remember when you said that we would get to this point, and I think we're at that point. And
Right.
and that's when you sort of say, I've met you on this journey, and we're going to take this path to the left together, and we're going to work through this, right? And I think that's the experience that we want to have in hospice, is meeting her, on her husband's journey and her journey, and not showing up at the fork in the road when she says, give me some more dexamethasone, and we say, no, sorry, that ship sailed, right? We don't want to be at that point, but we've got to be able to have that conversation earlier. And, I feel like, I can share those examples. I feel like we talk about those examples. I think I've given probably 200-300 presentations over the course of my career, nationally, and have shared stories like that, but yet you still hear about it. Like, it still happens. And so to me, it's like, if we haven't solved the problem at this point, and like the education only can go so far. At some point, we need to somewhat build that scenario out for them to sort of go through, right? And so that they can learn about it. Because by the people I taught that scenario to, 10 years ago, aren't in hospice anymore. They've retired. So I think that's where I think technology and the solutions and all those type of things go.
Hey, Jason, do you think, and what size, because you and I both know lots of pharmacists that are employed by hospice, at what size of a hospice does it make sense to hire your own pharmacist, ADC wise?
Yeah, I mean, I would say that it would not make sense for most hospices to hire their own pharmacist from a cost perspective. I would say that you would have to be north of 1,000 ADC before I think it really makes sense for you to hire your own pharmacist. Because I think you still have the price of drugs that you're still paying for, and I think pharmacy access, right, across the country since 2008 has become such a priority for everybody, that when you look at these, because when you hire your own pharmacist, the trouble that you have with it, and let me be really clear, hire your own pharmacist from just a pure consulting perspective, as opposed to, I have my own pharmacy and I'm dispensing, that's a different sort of story. If you're just looking at it from a consulting perspective, unless you have somebody who just wants to work part-time, who just wants to come Tuesday to an IDG meeting, again, a totally different thing. But if you were a hospice and you wanted to pay me, and I wanted to come to you, to your IDG and then help you out, that's a pretty hefty price to pay when, the most part, I'm not available 24/7. I'm not going to be available on the weekends. What happens when I go on a vacation for the week, right? Like, you introduce all of those other dynamics where I think from an education, from a pure accessibility perspective, so many of the providers in the space do such a good job of making themselves available 24/7, 365 that I don't think and most of them are going to come out at the price of a pharmacist or typically less than the price of a pharmacist. That it makes sense to sort of probably not necessarily hire your own. So I would say that, I would say it needs to be probably one of the larger hospice organizations before you start really looking at that. Again,
Yeah,
unless your program is very different. If your program is a big open access program who has a palliative care program and, maybe home health and you want to hire your own, like now you're talking about a lot of different scenarios than if we're looking solely just on hospice, if that makes sense.
yeah. I just find that we spend so much time talking about medication, especially in hospice. It's one of our biggest spends other than labor. It's, almost the second largest spend. Hospice, DME, medical supplies, physicians. And at some point, you just went through all these scenarios where we could educate, the clinicians better around hospice pharmacy. And I keep thinking, at what size do I hire a pharmacist to be on staff, one to help me manage costs, make sure we're controlling, we're paying for all the right things, we're reviewing all those drugs that we say we shouldn't pay for, or we are, so that making that person that responsible for that, manage my formulary, manage my, are we ordering the medications too early via mail order or too late via mail order? So we have all these administrative fees or delivery fees. And then how do I manage, these scenarios where in an IDG and, in Iowa, we have a scenario that we want to talk to a pharmacist about. And I'm sure we can call the pharmacy that's our vendor, but if we had our own pharmacist, could we manage those better? And then could we take that into an education level at a deeper level? And sure, the medical director is going to be a part of that conversation, but I don't know. It's something that's crossed my mind a few times is because medication, and especially when you start looking at your quality metrics and you're trying to manage pain and you're trying to really, do the right thing, keep patients from revocating. I mean, you have 10 patients that revocate and you could have avoided that through having a good pharmacist to talk to those patients. You've paid for that pharmacist
Right.
for that month. And so I keep going back and forth in my brain is at what size should we hire a pharmacist on staff and really put that job description in play that really helps one is save cost, two, manage the clinicians, and then three, educate and really educate well. And it should help our outcomes.
Hey, this is Alex with Steno Health. Our mission at Steno is simple: to improve the quality of life of the post-acute care clinician. Steno uses ethical, compliant AI to capture visits in real time and turn natural conversations into accurate notes and forms. We are clinicians ourselves, and we've designed Steno to never feel like an extra click or an extra burden in your day. The goal isn't to replace anything, but to support you in every aspect of your day so you can spend more time with your patients and still have the energy and freedom to be present with your family at the end of the day.
Yeah, I think the constant accessibility, the problem that hospice I think faces in general, right, is the average size hospice in this country. What is ADC wise? It floats around 65 or so, and
Yeah.
so so I think the trouble, right, is that when you get into when you're large enough to be able to pay for a pharmacist and utilize all the things you want, what you see happen is that those are spread across states. Right. And so it's very hard for this one central pharmacist. It's not like they're just coming into the organization and hitting all the IDGs and can go out and do ride visits. I mean, it's like I got to fly to, a different state or I got to drive somewhere. So I think when I look at the pharmacists that are today that are employed by a hospice directly, those friends that I have out there and you look at it, I mean, we talk about those struggles, right? And they say the same thing. They're like, I can barely get anybody on the phone at that location. And if I fly there, they're too busy. And like, it's hard to get the education done. And so I see their struggles with trying to get things accomplished that, yeah, they make a lot of great inroads. And yeah, but I mean, there's that tipping point, right? Where it's like, well, the savings is worth the spend, right? And how that's being managed. And so it's a unique concept, but it's definitely hard because as you see the hospices grow, you have a tendency to see them not necessarily grow in one central area. They start to
Sure.
spread out in multiple states and have different things, and that creates such a big dramatic issue with sort of with the pharmacist engagement. So.
Yeah, I just think about if you think about wound care, WOCNs, and not every patient needs wounds, right? And so not every patient has a pharmacy crisis or a medication crisis, but those one patients where you really are trying to solve a wound problem, and by the way, you might need a pharmacist in that scenario too. But I don't know. I keep in my brain. I keep going if you're a 5,000 ADC hospice, and you got patients all over the country. if you had a pharmacy resource that was on your staff that, anybody could write a note to, coordination note or whatever you want to call it into the pharmacy. Hey, I'm having a lot of problems managing this patient or medications, or, during our HOPE assessment, we continue to have pain problems with this patient. And we trigger that via, wow, shocker, we use clinical intelligence to trigger that. Now I have a group of pharmacists or a pharmacist team that can go and help my nurse and manage that. Again, ultimate outcome we want is for the patient to pass as easy and as safe as possible. But if I give that resource to my clinicians, or like, hey, you can schedule a meeting with the pharmacist and the patient, not necessarily in person, but via phone, there's nothing wrong with that. So I don't know. I'm going to keep playing with it more. I like it. Pharmacists are expensive. You guys make too much money, but you add a lot of value too. So what challenge are you seeing in the front lines of hospice pharmacy right now? And what deserves more of our attention? Anything jumping out?
I think for the most part, I mean, it's the same challenges that I think we've seen over the years. I think the one thing that's interesting about this space, right, is that the challenges have been the same. I think they continue to be the same. Everybody wants to save money. Everybody wants to, reduce their cost. The price of drugs continue to go up, just like the price of everything else continues to go up. But yet, everybody wants to pay less for their pharmacy spend. I think if I was to point at one thing that I think is really is kind of a hot topic that I think is going to show its ugly head here not too long, is really the lack of community pharmacy access.
Define that more.
If you look at community pharmacies, whether they're independent or you look at Walgreens, CVS's, you have seen a steady decline in some of those smaller independents. And you've also seen Walgreens and CVS remove a lot of stores or change their 24-hour stores to not being 24 hours. And I think that's one of the biggest challenges with hospice, obviously, is you have to. It doesn't matter if you love mail, right? You have to have a local partnership, right? Because you get a patient out of the hospital, you have to get them stuff now. You can't really necessarily rely on that. So when hospices are struggling and their conversations are, I don't have a 24-hour, I got to drive an hour and a half to get to a 24-hour pharmacy, that's a problem. And I think that lack of access to the medications is a big problem. And because when you lose those folks who don't want to deal with hospice, either the independent or the 24-hour store that wants to house that medication for you, and you end up with pharmacies who are a little bit more afraid, let's say, to carry morphine on the shelf, or doesn't want to put lorazepam and Tensol in their fridge, right? It doesn't want to put that stuff on the shelf. And now all of a sudden you're in that situation where, like, I can't even find the stuff I want. And so the roadblock, I think, is access. I think it's access to pharmacies. I think it's access to the meds. But I mean, those have been challenges for a long time. I think they're brewing more because I think you're seeing a lot of the smaller independents either get purchased, right, or close their doors. And I think you're seeing a lot of the chains look to cost containment strategies. And one thing to cost containment strategy is to get rid of 24-hour stores. And so you're seeing, it used to be there's a Walgreens and CVS on every corner. That's not the case anymore. Really, you see a lot of Walgreens and CVS corners abandoned now across the United States. And so I think it's a big challenge for pharmacy in general is access. I think if you were to poll nurses and you would ask them, like, would they prefer, to have a local pharmacy that carried everything for them, or would they prefer to have to go on an adventure every single time? They're always going to say, I'd rather have somebody I could call and get it from versus going on an adventure.
Sure. It's interesting in that I don't know the pharmacy stats, but my guess is just like all other, medical doctors, they're getting harder and harder to get out of school. It's getting harder. It's more expensive. Less people are wanting to go to be in the medical field. And so if we run out of pharmacists, we're going to have a problem too. And I think AI helps us a lot in that. But I understand the 24-hour pharmacy and why they don't want to keep a pharmacist live 24 hours a day. It's probably really expensive, and there's probably not a whole lot of action from 10 p.m. to 7 a.m. or 6 a.m. But I get it. But
You
thanks
know
for
just
bringing
as
that
well
up.
as I do that everything will be fine in hospice until we have that 3 a.m. crisis, and that 3 a.m. crisis will define the entire experience.
Yeah.
Um,
And we always say we only get one chance to do it right. And at 3 a.m., if I can't find the medication I need to get grandpa under control or get his anxiety down or whatever, I got a real problem. And it's, yeah, it's tough. All right, let's jump into you a little bit and some leadership and then a few more questions here. So I've personally called you one of the best pharmacists I've ever met. And I think the industry follows my guidance there. You've been on NHPCO, you've been around the industry for a long time. You've bought and sold I don't know how many pharmacy businesses. So I'm gonna label you that. Where does that come from? What made you become such an expert in pharmacy? I know you went to school for it, but a lot of people are. I mean, I went to school for a whole bunch of other stuff that I'm not an expert in. So what made you become the expert?
um, well, I think it kind of goes back to what we talked about earlier. I mean, the reality is that I think when you look at sort of that hospice experience, right, for me, right, I kind of I was able to have that philosophy of living in the gray, right? And so because of that, right, it was never it was never an all or nothing. It was never black and white. It was never yes and no, right? It was always, you can do anything you want, but I don't know that I would do it, right? Type of conversation. And, I think that is always, it just resonates. It resonated with a lot of people I've worked with over the years. I think it resonated with a lot of hospices. Like, I mean, lots of people would call me and say, this is what I want. This is what somebody tells me to do, and I would sort of just listen, right? And say, well, I mean, what do you want to do? And then they would tell me what they want to do. And then I would say, well, let's think about this. Let's run this out, right? How would you feel if this happened, right? And like, I was more always consultative, right? As opposed to saying, no, you need to do it this way, and I think for the most part that worked. I think it's what really enabled me to somewhat step into that NHPCO role, right? And be very channel agnostic, even though I worked, at obviously a vendor at that point, right? I mean, um, I was always channel agnostic. I always gave presentations. I always talked positively about every pharmacy company in the country. I mean, people would call me all the time from the HPCO boards, right? And they would say, "I need help with this," and it was never a conversation where I said, "Well, if you moved over to such and such, they'd fix that for you," right? I was always like, "This is how I would handle it," right? I always tell them, go back and talk to your current pharmacy. These are the things I would say to them. Ask them how they can help you with this, right? I would try to guide them to where the answer was, knowing that if they got the right answer, right, they could get those things done that they needed to get done. So I think philosophy wise, that has always sort of resonated with me. And I think I'll share a quick story with you because I think it kind of resonates and sort of kind of leads to the whole idea about what the philosophy I think of hospice kind of was and kind of like where my head was at, right? And the whole entire journey. And so um this is a this was a patient. So I had spent probably about a week or so, and I think I was in Texas. And I had spent about a week or so traveling around, visiting inpatient units, visiting hospice, branches, right, doing all kinds of education, physicians, nurses, and I came back home and the phone rang, and it was the executive director of the hospice, the medical director, and the nurse. And they said, "We have this patient in the IPU that we want to talk to you about." And this story was the patient's name was Billy. And Billy had Ewing sarcoma, which is a painful bone cancer. And
Super bad.
yeah. And he was in the inpatient unit, and the physician said we started him on dilaudid. He was started off on 2 milligrams an hour. He's up to like 240 milligrams an hour. I'm thinking about palliative sedation. I wanted to get a second opinion. Like, everybody's in crisis here about this. And um, we spent some time talking through, like, what is it that you did? What have they tried in the past? And we kind of came up with this plan where I said, I mean, I don't know that you need palliative sedation yet. Like, I think, based on kind of working through the scenario, I was like, I think we need to take 24, 48, 72 hours. We need to change some adjustments, put some different things in place, and let's see what type of response we get. And so they were very agreeable to that. So, we put on methadone, we scaled back some of the Dilaudid, we put dexamethasone on for the bone pain or whatever. We had also found that like some of his pain was really this bearing down pain. He had a rectal fistula that was associated with this, and he had this bearing down pain, and we put him on a little bit of Thorazine to help with that spasming sort of pain that he had. And, you know, 24, 48, 72 hours, like all of a sudden, like we've got his pain under control. He's doing really well. Like he's able to sit up in bed. And at that point, like, I kind of just bowed out, left, right? And sort of said, if you need anything, call me back. But like, I don't need to daily check-ins anymore, right? Because he's really comfortable. And so it was actually a year later that I showed back up in Texas, and I ended up in that inpatient unit, right, for an educational session I was doing. And I was actually like in their little conference room or whatever. And I was getting my laptop set up, right? And the nurse that took care of Billy actually came in and sat down at the chair, and she said, "Hey, I want to talk to you before everybody, gets in here." And she says, "Do you remember Billy and the pain crisis we had?" And I said, "Of course." And she had said that he had passed away peacefully. And of course, I said, "Well, I'm super sad that he passed away, but I'm happy to hear that everything stayed good and that he was under pain control." And she said, "You're not going to believe what happened." And I said, "Okay." And she said, about a week later, she said the mother and the father showed up at the hospice demanding to talk to the leadership team and the medical director, and they wanted to have this meeting. And so she was like, we all got in the room, we all had this meeting, not knowing what they wanted to say. And the mother speaks, and she tells them, she says, "We brought Billy to you, and he was in extreme pain, and you had a really hard time getting him under control." She said, "And then you figured it out, and you got him under great control. We were able to sit with him in bed. We were able to have great conversations. He died peacefully." And they said, "What you don't know is you don't know that he has a brother. And Ewing sarcoma is a genetic abnormality. And his brother also has the same genetic abnormality. He's 2 years younger." And she said he has already expressed the fact that he has Ewing sarcoma as well. It's starting to show its ugly head and with symptoms. And she said, she said, "We left out of this IPU," she said, "every night when he was in crisis." And she said, "We went home and we cried, and we saw him in crisis and pain and knowing that he was dying." And she said, "And then we looked at his brother who was sitting at the kitchen table eating dinner, knowing that 2 years down the road, he was going to be in the same position and cry. And he was going to be in the same position in crisis and not be going to die in pain." And she said, "You don't know the gift that you gave us when you allowed him to die peacefully." She said, "Because yes, we're sad that he's gone." She said, "But I know that his brother is also going to be able to die peacefully." And she said, "That was a gift that you don't even know that you gave us." And she said, "We just had to show back up here and tell you that." And I was
That's
like
cool.
shocked, right, when I heard this story, right, that this is what happened. And I think, you say that, like, what was that philosophy, right, from a pharmacy perspective, right? And, you look at it, and it's like, if you got into pharmacy because you were going to get a bunch of high fives, like, then you should get out, because that's not how it really works, right? And so, did they have any idea, about my involvement? Did they have any idea to know, like, what my suggestions were and how we, sort of managed that situation? No, they didn't have any idea about any of that. Did it matter? No. It doesn't matter, right? And so I sit back and I think about it, and I'm like, if I look at it from that philosophy, and I look at it and I say to myself, just over the course of the last 20 years, I mean, I must have touched indirectly millions of lives at this point, right? And so I look at that, and I think when you look at stuff from that philosophy, right, you look at it from that angle, that every time you do something, every time you do an education session, every time you do a presentation, every time you help a nurse, every time you help a physician, anytime you do all of that, you're helping not only them, but everybody downstream from them, because they're using that information. And that, to me, I think is sort of the reason that you get up and do it every day. Like, that's the reason I love hospice. That's the reason I've devoted, 20 years to it at this point, right? Is because of that. And I think that story encapsulates, your question about like, why do you think people gravitated towards you in pharmacy or whatever? And I think it's because that was my philosophy. My philosophy was always to do right by the patient. It was always to put the patient at the forefront of everything. It was always to figure out whatever it is that you needed. We needed to figure out how it was going to impact the patient. And I think that that sort of sat, and I think it always gave me that edge when we were in meetings, whether it was CMS, whether it was some type of regulatory environment. Like, it was always, well, I understand and appreciate where you're coming from. Let me talk to you how this is going to help. This is going to affect Mary Smith, right? When you require this, now this is the downstream effect. So can we work on this? So I was always able to negotiate sort of through that and advocate for hospice by talking through those types of lenses, right? And I think it always worked really well. It always kind of gave people a lot of I think confidence that scenario, those types of scenarios would help move the industry forward. And so I think, if I have that title, which, that's amazing that you say that, that I think that has a lot to do with why I ended up in that space.
Yeah, I think it's less about your title and more about your reputation, which is probably more important.
Yeah, exactly.
What a cool nurse for coming to you. Remembering, one, that Jason was sitting in that room, two, coming in and actually sharing that story.
I know.
We have software that we've created for bereavement at Maxwell Tech, and the stories that come back from these patient family members through these text messages are unbelievable. And if you get a little bit sad someday and you want to just, value your life, go read a bunch of those, responses that patients say. And it's just unbelievable. Like, it's why I'm in this business, right? First of all, I love technology. I love home care. I love hospice. I thought I wanted to be on the practice management EMR side of the hospitals. And I found a bigger love on this side because it's more, personal. It's longer term. On the April Anthony podcast, we talk about, every interaction with a patient needs to be meaningful because you may be the only person that person saw for 2 or 3 days, right? And so you have to make them meaningful. And every patient is somebody's family member, whether they're grandma, grandpa, mom, dad, sister, someone. That's a cool story. That's a really cool one. Really cool. Thanks for sharing that. Jason, a couple of last questions. What do you want your legacy to be? If people come back in 25, 30 years, or they're asking let's change the question a little bit. If they're talking to your kids, and I know you have kids, and I know you love your children very much. If they're talking to your kids and they say, who was my dad? What was his legacy? What do you want them to say?
Gosh. Man, I think at this point, right? I think it would really be, I hope that they're better because of something that I've done for them. Right. I think at the end of the day, right. I think the education, I think I'm an educator at heart, right? I think that's what I've spent so much of my time on, right? Has been, educating. And so, even though I love all this, technology and, you can do all this great stuff but education at heart, right? And so, I think touching so many folks over the years, I would want the legacy. I would want any legacy to sort of say, this is somebody who obviously cared a lot about the industry, cared a lot about the mission of hospice. And I'm a better hospice, X, right? I'm a better hospice physician. I'm a better hospice nurse. I'm a better hospice pharmacist because of the stuff that Jason had done. I think that to me would be the most impactful and most meaningful to me, I guess.
It's really cool. Yeah. Well said. And I hope someday your kids ask that question. If they call me, I'm going to tell them he always took my call. He was the best competitor I ever had. He was the best friend I ever had. He was the best pharmacist I ever knew. He had the best stories I ever knew. He drank more beer than everybody else, but he was a good guy and we had a lot of fun together. So it's been a great ride, Jason. Thank you so much for coming on and telling your story. It's an awesome one, and I hope everybody listens to it. It's you've really made an impact on the industry. And by the way, I know you're not done. So you might say you're done and you're going to retire and do all that, but I was the same way, and you're not done. You still got a long ways to go. You're still young, and you're going to continue to make a major impact on this industry. And I'm excited to see where you land next in your Yellow Leaf consulting business or wherever the world takes you.
Yeah. I appreciate you having me on. It's a real honor to be able to be on your podcast, and to give a platform to be able to tell some of these stories. I think to me it's just an amazing opportunity. So I appreciate it.